Good morning, everybody. This is a session which is going to introduce you to symptoms and heart disease and later to clinical exams for children with heart disease. Therefore, it is important that we start by understanding the common symptoms that children face when they have a heart problem. Dyspnea is of course one of the commonest things with which children can come. And you know that it is defined as an unpleasant awareness of one's own breathing. We also use the word tachypnea for a faster respiratory rate. And when you say that it is faster, you need to define what is the normal respiratory rate. In infants, if it is more than 40 per minute, you could consider it tachypnea. And in older children, rather say, in infants, you can see that more than 40 per minute, and in neonates, more than 60 per minute. If you are dealing with an older child, like a child who has, let's say, 8-year-old or 10-year-old child, a rate of 24 or 30 could also be considered abnormal. And the implications of dyspnea would be either pulmonary venous hypertension or hypoxia. We must also be familiar with the word orthopnea, which means dyspnea occurs within minutes of lying down. The obvious mechanism is an increase in the venous return and a decrease in the movement of diaphragm. Yet another word that you use is paroxysmal nocturnal dyspnea, often abbreviated as PND, which is a classic feature of left ventricular failure. It occurs 2-3 hours after going for sleep, and it is relieved in sleeping position. The mechanism of PND is a little more complex than simple orthopnea, or the mechanisms of orthopnea are relevant here also. Remember, during sleep there are different stages, and during the rapid eye movement or REM sleep, sympathetic activity increases, which causes peripheral vasoconstriction and an increase in the heart rate. This can precipitate cardiac failure. Or loss of sympathetic drive in NREM sleep can adversely affect the heart, which is badly dependent on sympathetic drive. It's something like turning off a drip of dopamine abruptly. So either of these mechanisms could be responsible for paroxysmal nocturnal dyspnea. And if you look at the pathophysiology of dyspnea in little detail, in left heart disease, there is left ventricular failure or AV inflow obstruction, as a result of which the AV end diastolic pressure is raised, epithelial pressure is raised, and there is pulmonary venous hypertension. When there is pulmonary venous hypertension, fluid transfers into the interstitium, and you need an increased respiratory effort to move the congested lung. J receptors in the interstitium stimulates respiratory center, and the increased inspiratory effort without proportionate lung expansion leads to intercostal or subcostal retraction. So this is how the actual symptom results. In the case of cyanotic congestive heart disease, there is an entirely different mechanism in operation, where hypoxia, which can lead to acidosis, and both hypoxia and acidosis stimulate the respiratory center, and hence the person becomes tachypneic. We need to quantify the amount of disability that a child has, and so we like to grade. Very commonly, the NIH classification is used in adults, and this is perhaps applicable without much difficulty to older children, where class 1 there is no symptom, class 2 there is dyspnea with ordinary activity, class 3 dyspnea on less than ordinary activity like climbing 2 flights of stairs, and class 4 is inability to perform any activity without dyspnea. Of course, the child or the adult is observing, he is in NYSA class 4. But the problem of extending this to infants is obvious, where there is no measurable distance that the baby is walking. So you need a different way of quantifying dyspnea in small babies. And this is what the Canadian Society did by using the Rose classification, where class 1, there are no symptoms. Class 2, there is mild tachypnea or sweating with feeding. In older child, if there is a dyspnea on exertion, this goes to class 2. And class 3 is marked tachypnea or sweating with feeding. Marked dyspnea on exertion. The feeding time is prolonged. There is failure of growth. So there is a failure to thrive. So class 4 is retraction, grunting, or sweating at rest, which are signs of imminent disaster. This classification, you can imagine, is much more useful in an infant and cardiac failure than the conventional NYHA classification. The other major symptom which a child or baby has is feeding difficulty, which is the main symptom in infants. It results from dyspnea and fatigue while sucking. What happens is that the baby sucks at the nipple, becomes dizzy, and stops after a small feed. During the interruption, if you watch, you notice that the baby is dizzy, tired looking, and has sweating over the forehead. It rests for a few minutes and starts sucking again. This is the suck, rest, suck cycle. Failure to thrive, which all pediatricians know has 100 causes, could also be due to cardiac failure. And failure to thrive, you would define a weight below the third percentile or a weight for height is less than 2 standard deviations per age. There are a number of reasons why a child with heart failure would fail to thrive. There is feeding difficulty and the consequent decrease in caloric intake. There is an increase in catabolism. There is recurrent respiratory infection, which also increases catabolism. Plus, systemic venous congestion causes portal venous congestion, anorexia, and decreased absorption from the gastrointestinal tract. Failure to thrive may be part of a syndrome like Dejo syndrome or rubella syndrome. Recurrent infection can also occur due to low immunity as part of a syndrome like Dejo syndrome. So failure to thrive in heart disease can be a complex, multifactorial event. The final endpoint is failure to thrive, and that does signify an important heart disease. If you look at recurrent respiratory infection, yet another symptom of some forms of heart disease, we should know that some episodes of lower respiratory infection in a year are the rule in normal children. So if you have more than 4 to 6 episodes of lower respiratory infection, or more than 2 episodes requiring hospitalization, or 2 episodes requiring IV antibiotics, these can be considered significant recurrent respiratory tract infection. It is commonly associated with post-tricuspid shunt, that's a VSD or a ductus or an AC window, which causes left ventricular failure and pulmonary venous congestion. The pathophysiology of recurrent respiratory infection is interesting. There is interstitial edema and pulmonary venodilatation causing compression of the bronchioles and retention of secretion. And when there is pulmonary venous congestion, anesthetic channels open between the pulmonary vein and bronchial veins, leading to bronchial mucosal congestion. And bronchial mucosal condition and goblet cell hypertrophy leads to impaired mucociliary clearance. Dilated left pulmonary arteries may cause compression of the left bronchus, resulting in retention of secretion and impaired clearance. Poor immunity associated with poor weight gain can also predispose to recurrent infection. Having dealt with dyspnea, failure to thrive, and recurrent respiratory infection, I think it's worthwhile spending some time on dyspnea and hypoxia, which I mentioned in passing earlier. When the hypoxic patient, typically the pathology type, exercises, there is an increase in the heart rate and the venous pressure with any other person exercising. There is also a systemic and there is an increase in the right to left shunt due to these various factors causing desaturation, leading to stimulation of the respiratory center and dyspnea. Exertional fatigue is the other symptom that we want to talk about. It denotes inadequate skeletal muscle perfusion during exercise. It is a feature of reduced cardiac output. And the causes would include a fixed arteriovenous obstruction, like in pulmonary hypertension or severe valvular pulmonary stenosis. Arteriovenous obstruction, I'm using the word figuratively because in pulmonary hypertension, you're not speaking of a structural obstruction, but the RV is unable to pump against a fixed resistance. Fixed LVOT obstruction, either valvular or subvalvular, can be a cause for exertional fatigue. Hence, aortic valve stenosis, discrete aortic stenosis, or hypertrophic cardiomyopathy all can be causes for exertional fatigue. The other important symptom that a child can have is syncope, which is transient loss of consciousness due to decreased cerebral perfusion. It may be exertional or it may be rare. Exertional syncope denotes inability of the heart to increase its output in the face of exercise-induced peripheral vasodilatation. Stimulation of the mechanoreceptors in the left ventricular myocardium can trigger a Bessel-Jarvis reflex, and this may be another factor in the pathogenesis of exercise-induced syncope. Arrhythmias like ventricular tachycardia or some forms of accessory pathway mediated tachycardia may be induced by exercise, and this could be a cause of syncope. And exertional syncope, let's remember, may be related to severe pulmonary hypertension, as in primary pulmonary hypertension or Eisenmenger syndrome, or severe LVOT obstruction. Syncope at rest is a very classic symptom of left atrial myxoma. In complete heart block, you get the Stokes-Fadden attack, which is due to asystole or ventricular fibrillation, which occurs at rest or on exercise. Vasovagal syncope is classical, the commonest cause of syncope in a child. It happens when a child is exposed to an unpleasant situation, has been standing for a long time, particularly in a school assembly. These can be the causes for vasovagal syncope. Palpitation is the other symptom which means an unpleasant awareness on heartbeat. Palpitation may be exertional, it may occur at rest. Exertional palpitation is the classic symptom of a volume overloaded heart. It happens with conditions like atrial septal defect, mitral regurgitation, or aortic regurgitation. These conditions may also cause palpitation to be appreciated when the child is lying on one side, when the volume overloaded heart comes closer to the chest wall. Palpitation at rest may be due to volume overload or an arrhythmia. A paroxysmal palpitation is classical of arrhythmia when there is an abrupt onset and offset. This history, remember, is always abnormal. The maximal heart rate is reached in 1 beat time. And I always remind my students to see the difference between paroxysmal palpitation and sinus tachycardia. In sinus tachycardia, think of your facing a viva. Your heartbeat increases as you are entering the exam hall, perhaps peaks when you are seeing your examiner. Depending on how you are doing, your palpitation varies. Once the exam is over, it quietens down over the next few seconds or over a few minutes. Unlike this, a paroxysmal palpitation is abrupt in onset and abrupt in offset. The maximal heart rate is achieved in 1 beat's time. And when it is released, the release is instantaneous, or in some cases, because of the associated anxiety, some degree of palpitation of a reduced rate may be present for the next few seconds or minutes. Associated symptoms and observant parents may notice neck pulsations or cardiac pulsations, and the child may have polyuria during the palpitation. And the child may give a history if he is older that a vagotonic maneuver like straining a stool may actually terminate the palpitation. The other symptom that you should know is chest pain. Perhaps the commonest reason for a child is brought to the OPD these days. You must remember that a chest pain in a child is extremely unlikely to be cardiac. Having said that, you should know the rare causes where a child would actually present with a chest pain due to a genuine cause. This may be pericarditis or pleuritis for that matter, in which case it's a short history, fever, and there is a rub. Far less commonly, a coronary artery abnormality can be a cause for chest pain. I would underline far less commonly. These coronary artery abnormalities may be an anomalous origin of the left coronary to the pulmonary artery, an abnormal interarterial coronary, both these are congenital, or it may be an acquired cause like Kawasaki's disease, which causes obstructive coronary artery lesions, or a Takayasu disease. A hypertrophic ventricle, right ventricle in the case of Eisenmenger syndrome, left ventricle in the case of an alveolar obstruction, may be a cause for chest pain. Mitral valve collapse is often listed as a cause for chest pain, but the chest pain in mitral valve collapse is more often imagined and is usually a highly strung young person with the knowledge of a heart disease who is complaining of an atypical pain is attributed to mitral valve collapse. So remember, words like mitral valve collapse as a diagnosis you should use carefully, and you must have criteria satisfied to diagnose mitral valve collapse. Otherwise, these people create one more neurotic. Yet another symptom which is important is edema or facial puffiness. It denotes systemic venous hypertension, and causes they would include congestive heart failure as the number one cause. It could be due to severe tracheal regurgitation. It could be posterior right ventricular dysfunction, as in total repair for pathology, or severe pulmonary arterial hypertension. The other important symptom, now you're coming on a symptom which is sort of overlapping with the sign, is cyanosis. You know that cyanosis is a bluish discoloration of the skin and mucous membrane due to increased concentration or reduced hemoglobin. If it's more than 3 grams in the ABG or more than 5 grams in the capillary blood gas, this is enough to cause cyanosis. And the causes, particularly in a newborn, remember, are more often non-cardiac. It could be neurology, it could be musculoskeletal, there could be an airway problem, there could be a problem with the alveolar capillary membrane as in ARDS, it could be an abnormal hemoglobin, it could also be cardiac. But if you are dealing with an older child, if the child is genuinely cyanotic, it is more likely to be cardiac. When you see a newborn with cyanosis, you face a question, is this central or is this peripheral cyanosis? Peripheral cyanosis occurs with cold extremities and it's very common in newborns and very young infants. In the newborn and the young infant, you also need to face the question, is it cardiac or is it respiratory? If the child is quite all right and the cyanosis is there, meaning we will call it a peaceful cyanosis, that's likely to be cardiac, whereas a baby who is in respiratory distress and has a lower saturation, the cause for cyanosis is respiratory. So when you see a cyanotic baby, you of course check whether the baby is cyanosed and the saturation will confirm, and you check whether the cyanosis is central or peripheral by keeping the baby warm. You see whether cyanosis is cardiac by looking at the respiratory distress and also the response to oxygen. When you do a hyperoxia test, you can do it by keeping the child on 100% oxygen for 10 minutes. That's on a face mask, 10 liters of oxygen. And you must have an arterial line. In the young baby, you would possibly have an umbilical arterial line. With the arterial line in place, with the hood, if you are giving oxygen, you expect that if the baby's heart is normal, that the PO2 would go above 300. That baby, if it has cyanosis to begin with, you can confidently say it is respiratory cyanosis. But if the PO2 is less than 150, it is likely to be cardiac. There is obviously an overlap zone which could occur in conditions like an obstructed TAPVC, where there is a cardiac cause while there is also a superimposed respiratory component. If you look at the arterial blood gas, you will find that if there is an ABG, you have checked the ABG, you will find a low pH, low PO2, and low PCO2. And if you are looking at the heart chest X-ray, the heart size, configuration, and vascularity all will tell you. In the ECG, if you are looking, an axis and right ventricular or left ventricular dominance will help you in reaching a conclusion. Remember, when you see a cyanotic congenital heart disease, you try to classify it as a reduced pulmonary blood flow, which could be due to tetralogy of Fallot or pulmonary atresia, which is the prototype, or a tetralogy-like physiology where there is a complex congenital heart disease, large VSD with pulmonary stenosis, or it could be a critical pulmonary valve stenosis or pulmonary atresia with an intact ventricular septum. In a Epstein's anomaly in the newborn, there could be cyanosis. Common features, Epstein's anomaly, of course, in an younger infant or an older person will also have cyanosis, but Epstein's anomaly in the newborn is a peculiar situation. The common features of the patient with reduced pulmonary blood flow will be low arterial oxygen saturation, X-ray showing erythemic lung, and a neonate responding to prostaglandin. If it is increased pulmonary blood flow, the prototype is transposition. You could have other causes like total anomalous pulmonary venous connection, single ventricle, truncal, GORV sometimes, particularly with subpulmonic VSD, and less commonly an AP window. AP window is not strictly a cyanotic congenital heart disease with increased pulmonary flow. It should more likely be classified like a VSD. The common features would be cyanosis, congestive heart failure, cardiomegaly, and uninterrupted murmur. A cyanotic spell is a very distinct event. It is a rapid decrease in systemic oxygen saturation with hyperventilation, leading to convulsions, coma, or death if uninterrupted. Classically, it occurs between 6 months to a few years and could occur up to 6 years. And the word cyanotic spell should be used carefully. Any baby with cyanosis will worsen with regard to cyanosis and the baby is crying, which should not be called a spell. You must consider that the hyperventilation component is mandatory to make the definition. Crying or exercise may trigger spells. The pathogenesis of the spells would include drop in the systemic vascular resistance, infundibular spasm in tetralogy, which exaggerates the right left shunt, causes acidosis, that is both hypoxia and acidosis trigger hyperventilation. This becomes a vicious cycle, and hence there is a rapid drop in the systemic oxygen saturation. This cartoon shows the child with tetralogy. If you see here, look at the infundibulum across which flow is occurring, and there is a VSV across which a right-left shunt is occurring, and this shows the infundibulum which has become much tighter, and there is a greater right-left shunt. And you would notice that the color of blood in the aorta has become more blue. Remember, you don't necessarily need this. A drop in the systemic vascular resistance will also encourage the right ventricle to come into the aorta. You also have cyanosis. You have a question? Sorry. I think I'll take the question just after this slide. I would come back to the question. Just to remind you that there is cyanosis in special situations like differential cyanosis. When you find cyanosis more in the lower limbs, often with clubbing, and this is classical of hypermelia PDA. In the newborn, persistent pulmonary hypertension in the newborn is an important cause for differential cyanosis. You also have a reverse differential cyanosis. It's the reverse of the pattern that you see in hypermelia PDA, where it is cyanosis more in the upper limb. This is classical of TDA with coarctation and PDA. Remember, if cyanosis is more in the upper limbs and the lower limbs have better saturation, the aorta should be getting a better saturated blood, the descending aorta, and that could happen in PDA when the PDA shunt brings the better saturated blood into the lower limb and coarctation facilitates this. And if the heart is actually normal, and there is cyanosis, that is structurally normal heart, a pulmonary arteriovenous fistula is the most likely cause. You could also have a systemic venous anomaly, like an IVC connected to LA, or a left superior vena cava connected to LA. So these are common abnormal situations where cyanosis is seen, and that I think would conclude my talk on this. Before I ask you the questions, I think I should take you to a question. Let me see these questions. Can you hear me now without the voice cracking? There is a lot of, I'm very sorry about that. There has been some technical problems in the webcast today. There is a question as to, yes, I think one method is, I think you had some diagnosis as to why the disturbance was coming. If all of you have muted your mic, it should have improved. I'll answer this question and let me know whether you heard it. Now, Dinesh has asked the question, why the spells reduce after a certain age? There are some reasons for this. If you take a spelling, let's take a spelling tetralogy as an example. If a tetralogy with a spell, which was in spells, is surviving, that should mean that either collaterals have developed or you have done something for the child. And if it's a child who is scratching, has learned to restrict the exercise. And if you look at epidemiology of pathology side, if you look at the number of children who survive, those who are significantly symptomatic, the survival is coming down. Therefore, you are far more likely to see a child without a problem at the age of 5 years than at the age of 6 months. So, when you say that cells are decreasing after a certain age, one of the reasons is that the spelling child is disappearing from your vision. These children are dying away. And those who survive, they get some benefit by beginning to appear flat, the occurrence of the learning to restrict exercise. These mechanisms allow them to survive, and then cells do disappear. Just tell me whether you heard it, or more importantly, whether you followed it. Okay. Yeah. Any other questions? Then I'm going to ask you questions. Maybe. Okay. I'll be staying on the slide and waiting for your response. The question: what respiratory rate will be called tachypnea in a 5-day-old baby? 40, 52, or 68? Okay, it has to be more than 60. Remember, in that context, when you're seeing a neonate with a rate of 60, see whether it is sustained. It is a sustained tachypnea at this rate which is important. Because if you are watching a baby, especially in the first few days, you'll find the baby breathing very fast intermittently and then quietening down. But if the baby has a sustained tachypnea exceeding 60, that is up. Now you have seen the second question also. Which of these dyspnea in a child does not occur due to the following reasons: hypoxia, systemic venous congestion, pneumonia, myocinosis. Good, Divyesh. It is 2B. The systemic venous congestion can cause edema, facial puffiness, hepatomegaly, but it does not cause dyspnea. But on the other hand, hypoxia, any left heart obstructive lesion like myocinosis, or respiratory problem will be a cause of hypoxia. And failure to thrive in a child with heart disease is due to heart failure, hypoxia, syndromes, or any of the above. Yes, Divyesh. All of these can be causes for failure to thrive. It can be heart failure, it can be hypoxia, it can be syndromes like visual. Then they contribute to failure to thrive. And the next question, look at 4. Exertional syncope may be due to aortic stenosis, isolated syndrome, primary pulmonary hypertension, vasovagal syncope. You can choose one, any, or all. Why do you leave out D? Why do you exertional syncope? Vasovagal syncope is not exertional, so that is a smart response. All the others produce exertional syncope, like vasovagal syncope is very unlikely to be related to exercise. Things like prolonged standing cause it. So vasovagal syncope is not an exertional syncope, the others are. This, you don't have any options. You will need to answer what is the minimum level of reduced hemoglobin in arterial blood gas in a cyanosis style. Yes, it is 3. So, if the reduced hemoglobin is 3 grams per mole, and cyanotic cell is a feature of the following: pathology, pulmonary, or all. Question number 6. Yes, Dept.of, it's only pathology. Valvular pH with intact ventricular septum, even if it causes cyanosis, it does not cause a cyanotic spell. Hypermelia syndrome definitely does not cause, and nor does extreme. So cyanotic spell is a feature of pathology. We use the word in mainstream. Pathology like physiology will also cause cyanotic spell. Now look at the next question. Reverse cyanosis is seen in which of the following? Reverse differential cyanosis. Good, Dept.of. It's only PGA, ductus, and intracaudal in this option. So those are your answers in a nutshell. If you have any questions, I can answer that. You don't have any questions? I'm going to sign off then. Thank you then. We'll meet on Thursday morning, 8 o'clock. Thank you. Do you want to leave this meeting? Leave it.
Hello.